I don't know why I don't see this. Okay, now it is. Okay, so I present you a study conducted at the University Hospital of Florence in the pelvic perineology unit and the urology department about this robotic assisted intracorporeal, total intracorporeal neobladder reconstruction with the middle term results and the functional outcomes. So these are, I don't know. Okay, it's a little slow, sorry. These are my disclosure and I have nothing to disclose. So the background is that neobladder reconstruction is a challenging and invasive surgical procedure, and the robotic assistance seems to reduce stress, surgical stress, and allow for a more precise and anatomical dissection. In our institution, some different techniques have been adopted during years, and so the fluorine Ileal Neobladder is the results of the development and the adjustment of the technique, and it was mainly developed to produce a faster and easier reconstruction and a totally intracorporeal reconstruction. It has been conducted according to the Ileal concepts, and we are now in the assessment phase because 72 procedures have currently been performed since 2016. Our oncologic outcomes shows that the procedure is safe, and also the literature evidence provides the same results. So we choose to evaluate the urodynamics results of our patients at 6 months after the cystectomy, because we consider this as a good maturation time to stabilize the urodynamics results. And we perform the comparison between the gold standard open performed Ileal Neobladder, Padovana Ileal Neobladder, and the flooring technique. So for the patients that were not able to undergo the urodynamic examination, the continence assessment was performed by an amnestic assessment. And these are the demographics and the follow-up features. So from 53 patients reached 1 year, at least 1 year of follow-up from the group of robotic-assisted radical cystectomy, while 49 patients were included for the open radical cystectomy of Ileal, Padovana Ileal Neobladder. Median age at surgery was 66 for the robotic-assisted procedure, while it was 61 for the open cystectomy, and the follow-up time was similar between the two groups. From the anamnestic assessment of continence, we had 66 patients, 37 robotic procedure and 29 open cystectomy. And you can see how the social continent that was defined in a little bit higher threshold compared to the incontinence surgery. So we used the definition of 2 pads per day. Both groups achieved 3/4 patients were social continence. The strictly dry was similar also in the two groups, and a small difference, not significant one, was seen for patients that needed a clean intermittent catheterization because of post-void residue. Urodynamic features were the following, and we registered a little bit lower percentage of female in the robotic assisted procedure compared to the open cystectomy. But all the parameters didn't show a significant difference between the two groups. So the cystocapacity was similar, the post-void was similar, and also the Qmax non-invasive flowmetry was similar between the two groups. The only significant difference that we found was about the compliance, that was a little bit higher in the robotic assisted procedure, and similarly the leak point, pressure leak point was a little bit higher for the robotic assisted procedure. These differences might be linked with a more conserved vascularization for the robotic assisted procedure. Maybe this is not evident yet, but we suppose that this can be a cause. And similarly, the higher leaking point might be the consequence of a more precise and a more anatomical dissection during the demolitive phases. So, for conclude, we can say that functional results of the midterm support a convincing evidence in favor of robotic assistant and total intracorporeal robotic reconstruction. And the prosecution of the study with more urodynamic study and also the analysis of the quality of life will give us further insight on the long-term results. Thank you for your attention.
So are there any questions from the auditorium? Just a quick question. There's a question?
Marcus Drake, University of Bristol. I think this is fantastic. My one comment is you did say that 6 months you felt was enough time for recovery. I'm not quite sure I agree. When you do a radical prostatectomy and then you're doing the recovery after that, it's at 6 months really that it starts, basically because of the re-innovation. And you do describe a significant difference in your leak point pressure. So I wonder if you could explain a bit about the duration of recovery that you allowed before measuring the leak point pressures.
For the timing, I really appreciate this comment because it can be, and maybe in the future we are moving to make the assessment on a little bit longer time and see if it can give different results. And for the leak point pressure, I don't really get precisely the question, but
I think you said there was a difference in the leak point pressure between the groups.
It was not significant, the difference. It was just
60 versus 37, so it was noticeable.
It was 0.9, so it was almost significant, and maybe further studies will give us more statistical power to calculate it better, to have better results.
Thank you very much.
Thank you.